Good afternoon, everyone. My name is CB Mamaril, and I will be your moderator today. And on behalf of the University of Kentucky, PBR, and PHSSR National Coordinating Center, I would like to welcome everyone to today's webinar as part of our PHSSR Research in Progress series, focusing on the costs, quality, and value of public health services. We have an exciting topic today on the population health investments, relationships between governmental public health and hospital community benefit spending. And it looks like we're also going to have a record number of attendees. And just to remind everyone before we get started that you can download today's presentation and speaker bios if you see the resource box in the top right corner of the screen. And so as we get started too, I'd like to also encourage everyone, if you have any questions, even during the presentation, you can start typing them on the chat box at the lower right-hand corner so we can get to them right after the commentators also get to give their commentaries. So it is our pleasure to introduce our presenter for today's webinar, Dr. Simone Singh, who is an assistant professor of health management and policy at the University of Michigan School of Public Health. Simone is trained in accounting and finance, and her research agenda focuses on improving our understanding of accounting practices and financial management strategies of both healthcare and public health organizations. For the past 4 years, Simone has been engaged in research related to legal and financial aspects of not-for-profit hospitals, provision of community benefits, and how hospitals' community benefit activities can be used to improve population health outcomes. In addition, Dr. Singh conducts research on costing healthcare and public health services. Most recently, the focus of Simone's work has been on examining the differences in productivity and efficiency in service delivery across local health departments. Simone received her PhD in Health Services Organization and Policy, and also her MA in Applied Economics, both from the University of Michigan. So it's our pleasure to introduce Simone, and Simone, you have the floor.
Thank you, CB, and good afternoon, everyone. I'm really delighted to have the opportunity to present this study here today. And this work is a joint project with Dr. Gary Young, who's on faculty at Northeastern University, where he directs the Center for Health Policy and Healthcare Research. So let me begin by providing a little bit of context for this work. So as many of you know, local and state health departments play an important role in providing essential public health services in communities across this country. Yet, of course, they're not the only ones to do so. There's many other stakeholders, hospitals, healthcare providers, insurers, schools, community nonprofits, employers, you name it, who also engage in activities aimed at improving population health. So tax-exempt hospitals, which I've been studying, for instance, invest in population health improvement as part of their community benefit activities. And so some commonly provided activities that target the health of the population more broadly would include immunization campaigns, cancer screenings, and health education initiatives. Many of these services, of course, are also provided by others in the community, including the governmental public health agencies. And at this point, we really know very little about the interplay between public and private investment in population health. And so this is what drove us, what motivated us to conduct this study. So the conceptual framework we chose for this study is the economic theory of crowd out. And so this theory basically suggests that increased public sector spending may reduce private sector investment, a so-called crowding out of private sector activity. And so within the healthcare sector, studies have shown crowding out of private sector engagement, for instance, in the health insurance market. So you may know, you may have heard of that. But for instance, in the public health insurance expansions in the 80s, 90s, and early 2000s, research has found that there were crowd-out rates of about 50 to 60%. So the number of uninsured fell by only about 50 to 60%, as much as the number of publicly insured rose, due to offsetting reductions in private insurance coverage. So we were interested in studying whether crowd out also occurs in other areas, and specifically in the area of investing in population health improvement activities. Does spending by, or higher spending by local and state health departments on population health activities crowd out or reduce similar types of spending by private sector organizations such as hospitals? We know from a lot of prior and ongoing research that public health spending has been shown to be associated with improved population health outcomes. So increases in spending have been linked for many different states and many different types of programs with improved outcomes. So consequently, you could think that greater spending by government public health agencies may reduce unmet need and therefore improve population health outcomes, and so reduce the need for private sector investment. But so we wanted to try and shed a little bit more light on this. So prior empirical evidence on this relationship between public and private sector investment in population health is fairly limited. We conducted a study not too long ago that looked at the state level and looked at the relationship between governmental public health spending at the state level and hospital community benefit spending at the state level as well. And we found no relationship between public and private investment in population health. However, as we are all aware of, state level analyses are pretty limited because they don't take into account the substantial variation in spending within communities, within different states. So the goal of this study then was to examine the relationship between public and private investment in population health at a more granular level. And so the research question specifically that we looked at was whether public sector spending, specifically the spending by local and state health departments, was associated or related to private investment in that area, specifically looking at the tax-exempt hospitals and their provision of community benefit. And so following economic theory of crowd out, we hypothesized that greater public spending on population health would be associated with reduced hospital community benefit spending and vice versa. So the data for this study came from a number of data sources that we were able to merge together. So hospital community benefit spending came from their tax filings, more specifically IRS Form 990, Schedule H. We obtained local health department spending from the 2010 Nature Profile Study. State health department spending came from the Association of State and Territorial Health Officials, specifically their profile of state public health. And then we had additional data sources, the American Hospital Association's annual survey, the Centers for Medicare and Medicaid Services, and the Area Health Resource File. And we mainly derived additional control variables for the analysis from these last three data sources. And all the data we have were for the years 2009, 2010. And at the point of the analysis, that was the latest year for which we had all data on all the variables we needed. Now we are just getting data for 2012, 2013, so we hope to replicate this again in the near future, but currently this is all we have for this presentation. So here is how we derived the sample. So maybe just a quick note. The unit of analysis here was the individual hospital and the corresponding local health department. And so how we derived the sample was as follows. So we had about 1,800 Forms 990 Schedule H. Basically, we had 990s for all private tax-exempt general hospitals that completed this form at the individual hospital level in 2009. And then for each of these hospitals, we identified the county in which the hospital was located. And then based on that information, we merged the corresponding health department that served that respective county. Because not all the health departments in the U.S. participate in a 2010 Nature Profile, this process only resulted in complete hospital HD pairings of about 1,500 of the 1,800 hospitals. For about 83% of hospitals who were able to merge the corresponding health department using data from the Nature Profile. And then we had to further reduce our sample to about 1,100 hospitals, primarily because we didn't have complete information on all variables of interest, specifically the spending variables in both the NATRO and the ASTO profiles are sometimes not complete, so we had to further reduce our sample to take that into account. Okay, so the subsample of hospitals that we ended up with for our study was actually, maybe surprisingly, but actually fairly similar to all private tax-exempt hospitals in the United States in terms of some key characteristics. And so here I show size, number of beds, teaching status, geographic area, urban, rural, and the list could go on. There is one exception, however, maybe not surprisingly. system affiliation is a bit different. So due to the fact that many health systems have what we call a group exemption, and so they don't report their community benefit spending at the individual hospital level, but at the group, at the system level. System level hospitals in our study were underrepresented in this analysis. So that's not really surprising, but something I wanted to point out here. Okay, so let me share with you some descriptive results first. So in 2009-2010, median total spending by local health departments was about $4.7 million, or approximately $39 per capita. And median total spending by state health departments in that year was about $451 million, or about $70 per capita. So once you adjust for double counting of certain funds that both local and state health departments count in their budgets, together we derived a per capita spending of about $93 at the median. So if you look further down at tax-exempt hospitals, the median total spending on all community benefit activities was about $7 million per hospital. And then if you just look at what's going toward what we call community health services, or broader services that target the health of the population more broadly, that spending at the median was about $300,000 only. So the majority of the 6.9 or 7 million the hospital spend goes toward direct clinical care, such as charity care, Medicaid shortfalls, and other subsidized health services. And then in order to adjust for the size of hospitals, so different hospitals have different sizes, what we usually do is divide total spending into the overall operating budget of a hospital. So we divided total community benefit spending into total operating expenses. And so that gives us a median of 6.4. And then similarly for community health services, the median spending by hospitals on these types of services is about 0.3% of total operating spending of the hospital. And just as a heads up, for the multivariate analysis, our variables will be defined in terms of the per capita governmental public health spending and the percent of operating expenditures for the community benefit variables. So this graph shows that median hospital spending on community health services by decile of governmental public health spending in a county. Right? So what we see is that median hospital spending varies quite a bit, so it ranges from about 0.2 to about 0.4% of total operating spending. But if you look at this graph, you really don't see a clear relationship between the level of hospital spending on these types of services and the level of governmental public health spending. And in line with this graph, we also conducted some bivariate correlation analysis. And so the results are here on this slide. So you can see that there's really, with one exception, no statistically significant correlation or relationship between any of our hospital variables and any of our public health spending variables. So with the one exception of state health department spending and total community benefit spending, where there's a weakly negative relationship, there was no relationship, specifically no relationship between the broader community health services spending and any of the governmental public health spending variables. So in addition to the descriptive analysis, we also ran the following multivariate model. So we expressed community benefit spending of a specific hospital, hospital I, as a function of the per capita spending incurred by both the local and state health department that served the county that the hospital is located in. And then we controlled for a set of hospital, local health department, state health department, and community level characteristics. All of the regressions were estimated using generalized linear models, and we ran two separate models for the two dependent variables, so for total community benefit spending and for community health services spending specifically. And then, as I said, we include a set of controls, and I'm happy to name some of them. So hospital level controls include number of beds, system affiliation, church affiliation, teaching status, and for instance, things such as hospital profitability, whether or not the hospital was a sole community provider, etc. For the local health departments, we included jurisdiction size, type of jurisdiction served, type of governance, whether or not there was a local board of health, and then also the proportion of all services provided that represented clinical services. For the state health departments, we also include a variable that looked at the proportion of total spending that targeted clinical services. And then for the community level controls, we had characteristics around market competition, the percent of hospital beds in the community that are controlled by for-profits and public hospitals, whether or not the state had a community benefit reporting requirement, and then different location indicators such as urban, rural, as well as geographic region. So we, the census region. Okay, I'm trying to see, okay, there's a question, what's this here? So this was not a hierarchical linear model, and did we adjust for, we did not use the log of spending. We've run this model in different ways, and this seems to be the best specification, so we did not do that. We've run other, we've published other papers using a similar approach, and we've not used the log there as well, but we certainly run, different versions of the model in the process of deriving this final model. Okay, so the coefficient we're specifically interested in estimating was beta 1. So our theory of crowd out here would be supported if we had found, or if we find a negative and statistically significant estimate for beta 1. And that's not what we found. So here's a snapshot of our multivariate findings. So consistent with our bivariate findings, you can see here in the first row that hospital provision of community benefit was basically not associated with our governmental public health spending variable. So neither total community benefit nor these community health services were associated with how much the local and state health departments spent on public and population health more broadly in a community. And further down, you can see that really there was only a handful of the many control variables that we included that were significant. None of the local and state health department controls were. A number of hospital-level controls, maybe not surprisingly, were significant. So we see here, for instance, that the number of beds was positively associated with total spending. So larger hospitals provide more community benefit. We see that being a teaching hospital was associated with higher spending. So teaching hospitals doing more than non-teaching facilities. Interestingly, being a sole community provider as defined by CMS was associated with higher spending on community health services specifically. So that may indicate that hospitals in these communities may take on a much broader role than just being a clinical or hospital care provider. And then, the last row here shows the only variable that was significant out of all the community level controls. And so we found here, as we did in prior studies, that a state level reporting requirement seems to be associated with higher spending overall, but not with greater spending on community health services. So to summarize our key findings, we found no evidence, at least in this model, with these specifications, of crowding out of hospital investment in population health activities by the public health sector. So both the size and the composition of a hospital's portfolio in terms of what they do for community benefit was unrelated to the level of governmental public health spending in the respective county. And then more generally, as I briefly mentioned, none of the other local and state health department level characteristics included were significant predictors of community benefit spending. So as you may have already noticed, or as you can tell, this study has a lot of limitations. It's one of the first studies looking at these relationships, but there's definitely a lot of issues methodologically, and I want to highlight a couple here. First of all, as I mentioned, the data for the study was just for 1 year, 2009, and so 2009 was the first year that tax-exempt hospitals were required to report on their community benefit activities in that revised IRS Form 990 Schedule H. And what we found, and what we've heard anecdotally is that reported spending, may differ, or, maybe often differs from actual spending, in particular in those non-clinical categories where many hospitals historically really have no good reporting system in place to track activities and expenditures. And so they may have to rely on estimates when completing Form 990. Second, we merged hospitals to local health departments based on the county in which the hospital was located, and of course it has its limitations. So for instance, a hospital located in County A was merged with data for the health department that serves County A. That was our algorithm for the merge. However, of course, hospital service areas differ usually from the county the hospital is located in, right? Some hospitals serve only a part of the county, but they also serve patients in neighboring counties, which then may be served by a different health department. Or if you think of a rural health department, right, a rural hospital, right, that hospital may serve multiple counties. And then again, these multiple counties may be in the jurisdiction of one or of multiple different health departments. So there's definitely going to be a need for future work in this area to refine the definition of community served by a hospital and to refine that matching process. It was hard to do this at a national level, without really great insight into regional or state level structures. Third, the unit of analysis for the study was the hospital LHD pairing, not the whole community, right? So we are at least unaware of, data sets that are, easily or at least accessible, eventually accessible, that would allow us to pair the amount, the spending data that we have for hospital health department with the spending for other providers, right? So if you really wanted to study what this looks like in the whole community, right, we would need information about investment in population health of all these different stakeholders that I mentioned in the very beginning. So future work is definitely needed in this area, and maybe at the regional or state level, there are data sets that could be used to do that. And then finally, one caveat with the 990 data is that we only have benefits measured in terms of the net cost incurred by a hospital. So the new Form 990 does not have any information on the specific types of benefits that a hospital may invest in. So while we didn't see any relationship between the amount spent, right, there may well be relationships between the types of programs that hospitals specifically engage in. So we may well see that the types of programs and activities are much better coordinated with public health or other activities than what our data can tell. Okay, so let me conclude with some implications for policy and practice from our perspective, and then I look forward to hearing the commentary by Glenn and Charles and Dr. Barnett. So the level of governmental public health spending, as we've seen here in the community, does not appear to crowd out investments of hospitals in population health improvement. And so given that overall there's a fairly low level of investment in public health in the U.S., this finding is actually quite encouraging. And to many of you, I suspect the lack of a relationship that we found between governmental public health and hospital community spending may not be very surprising. Indeed, some of you may ask, why would there be a relationship? Like, it doesn't make sense, or it's not something we would have expected based on our experience working in the field. So, there may be that may well be true. Nonetheless, we think that this finding of a lack of a relationship does raise some questions, especially questions about the extent of communication among different stakeholders in the community, and it may also, provide or highlight some opportunities that may exist for different stakeholders to more actively, collaborate on community health improvement planning. So there may be opportunities for public health to engage private sector stakeholders, right, to ensure that different spending really complements one another. And many of you, may know this, or I've also talked about this at various occasions. There is a new requirement, especially for tax-exempt hospitals under the ACA, that hospitals now have to conduct periodic community health needs assessments, or CHNAS. And the new IRS regulation stipulate that these assessments have to be done with, the input of the local health department or public health in the community. At the same time, as many of you know much better than I do, there are now incentives for health departments who want to get accredited to conduct a community health assessment. And so often now in communities we see joint activity around these assessments. And so that's actually a really great development also for the purpose of this kind of work that we're doing, because once you have a partnership in place, right, between hospitals, local public health, and others in the community to do these joint assessments, you may be in a really good position to build on those partnerships and then also move into joint community health improvement planning, which may help to better align eventually public and private investment in population health, which we're not seeing right now, but which may be something that we hope to see in the future. So thank you very much, and I'll turn it back to CB.
Thank you, Simona. And we'd just like to remind everyone and encourage everyone that after the commentaries, we will be proceeding to our questions section. And so we encourage you to start typing in your questions on the chat box so that we could get to them immediately. So before we get to the commentaries, I'd like to introduce our three commentators for this afternoon's webinar. And first off, we have Chara Stewart-Abrams, who is the Administrative Director, the Department of Psychology at St. Jude's Children's Research Hospital in Memphis. And at St. Jude, Chara, which she joined in 2011, leads a department of over 70 faculty, staff, and students with the opportunity to drive engagement and implement strategic planning and quality management to ensure high performance and alignment with St. Jude's mission. Chara serves on St. Jude's Community Benefit Advisory Team and advises and mentors St. Jude's Leadership Program participants. Chara also previously directed the Cancer Control Outreach Center and managed the Arkansas Cancer Community Network at the University of Arkansas for Medical Sciences, Winthrop D. Rockefeller Cancer Institute. Our next commentator will be Dr. Kevin Barnett, who is a senior investigator at the Public Health Institute in Oakland. And for the past 2 decades, Kevin has conducted applied research and fieldwork on 2 distinct but related issues: the charitable obligations of nonprofit hospitals and the diversity of the health professions workforce. In 2006, Kevin completed a multi-state demonstration project involving more than 70 hospitals. The project was entitled Advancing the State of the Art in Community Benefit to develop and implement uniform community benefit standards. He is working with leading-edge health systems to implement these standards at the national level and partnered with the National Network of Public Health Institutes to convene a series of community benefit regional roundtable in 7 states. On the health professions workforce diversity issue, Kevin served in 2004 on the Institute of Medicine Diversity in the Healthcare Workforce Committee, and also co-authored the Sullivan Commission report on minorities in the health professions. And our third commentator will be Dr. Glenn Mays, who is the director of the National Coordinating Center for PHSSR and Public Health PBRNs, and he is also the Scotchfield Endowed Professor at the University of Kentucky College of Public Health. Dr. Mays' research focuses on strategies for organizing and financing public health services, preventive care, and chronic disease management for underserved populations. Glenn's a graduate of Brown University and earned a PhD and MPH in Health Policy Administration from the University of North Carolina, Chapel Hill. And he also completed a postdoctoral fellowship at the Harvard Medical School Department of Healthcare Policy. Prior to joining the University of Kentucky, Dr. Mays held a faculty position at the University of Arkansas for Medical Sciences, and he was also a senior health policy research at Mathematica Policy Research. So with that, Chara, I'd like to turn over the commentary to you.
Thank you. Thank you very much. And hello, everyone. Thank you for this opportunity to participate in this important discussion. I am providing points from a hospital perspective, as he mentioned, and actually, great segue toward the end of the presentation, because I'll be providing commentary from the implications that insurance coverage provided by the passage of Affordable Care Act has allowed nonprofit hospitals to use their community benefit program to support broad-based community prevention rather than primarily focusing on charity or uncompensated care. qualify for federal tax exempt status. But however, hospitals will continue to be an important safety net for uninsured and underinsured population. The data is very important because in public health and in population health, data is especially important as most deaths are attributable to modifiable behaviors, as you all from public health know, with the highest numbers linked to tobacco use, poor exercise, and diet. And as a person with a public health background and a way for me to remember certain things as I present, I have to have something catching like the ABCs or acronym to help me remember what I'm going to speak on in my commentary. So I have something called the ABCs that tie community benefit and population health. So for the A, I think what's very important, of course, with the community benefits, access the access to the needs and determining current assets. Um, with the requirement of the community health needs assessment, communities are involved in identifying the needs by serving on hospital and health systems. I'm sorry, let me go back. Communities involved in identifying needs are important to serving in hospitals and health system committees, which allows us to use the community health needs assessment as a planning tool. And this will also help to inform community decision making and develop and implement community health improvement plans. This will also help hospitals as they're looking at the community health needs assessments realize how they should be able to allocate their current resources and their current assets. The B in the ABCs uh, is what I say that's another important aspect is building healthy communities. And with building healthy communities, the hospital community benefit programs appears to be an important opportunity for hospitals to further advance their path towards the Institute of Healthcare Improvements, triple aim. And I think this may have been briefly mentioned earlier. And improving with the triple aim, improving the patient experience of care, improving the overall health of a population, and providing high quality care at an affordable cost, which is very important. And in a recent report produced by the American Hospital Association committees on research and performance improvement, while issues of access, cost, and quality, they mentioned issues of access, cost, and quality were drivers for the Affordable Care Act. Response to these changes are now being formed through both payment and delivery system reform. Of course, hospitals are using the triple aim to guide them as they look different paths and approaches to redefine themselves and further develop strategies and build business models for sustainability. They are improving the overall health of our country and our community and our patients. So with that report, they've brought out some major implications in how the governing boards should be active in engaging the communities and also applying this to their strategic plan. Also, with building healthy communities, I'm very interested in addressing the determinants of health, which are important for you all that are in the public health field, know these pretty easily. But according to an article in a recent article in Health Progress, states that addressing the determinants of health is a key way community benefit and population health. And this is only really, to me, the way that we can, these two can work together, both community benefit and population health. Public health experts agree that population health reflects the influence of much more than health services. So where health determinants are not just looking at the health services that are provided, but looking at a comprehensive approach in addressing the needs of the community and looking at how we can be more effective with the addressing the community benefits. The C of our ABCs are the collaborative partnership. And with collaborative partnerships, that entails everyone. As Dr. Singh mentioned earlier, that both local and state health departments and hospitals should um, work very closely together because we have a lot of the same end goals in common, especially looking at what the community needs are. But approaching them, I guess, would be how we would differ in some ways, depending on what each person's agenda is. But one framework that I've done a little research on is the collective impact framework, which helps all of these multiple stakeholders align common agendas and share measurement systems, mutually reinforcing activities and which provides also continuous communication. That was one of the points Dr. Singh mentioned earlier, is how, there may be a gap or a deficit in the communication between the organizations or the stakeholders that are involved in community benefits or community health activities. And also having a organization that is pretty much spearheading this particular, whatever the goal is in addressing the community's needs. And that will conclude basically the collective impact framework. But as was mentioned, communication is very imperative, and providing care in a coordinating manner is also imperative. As hospitals shift from um, volume-based systems to value-based systems, this is also going to be important that from the beginning we understand what the needs are and how our physicians can address those needs and assist our patients. But over time, hospitals can align their community benefit investments in these community-based activities to increase both the health care savings and improve the community's care and their health. So ultimately, I just wanted to say, from a hospital's perspective, this would the involvement with all of those stakeholders are very important, and none of this could actually be accomplished effectively if not having that involvement and having substantive involvement and not just collecting the needs, but actually addressing those with the implementation plans that are required with community benefit Schedule 8. And that concludes my comment.
Thank you, Chera. Dr. Burnett, you have the line.
Terrific. Thank you very much, and thank you for the opportunity to participate in this discussion. I think this is a fascinating area of inquiry that Dr. Singh and Young have taken on, and I'm particularly intrigued by the whole notion of crowding out. And in part, my first reaction was, well, this notion of crowding out has a bit of a negative connotation, and I think it is open to question in a number of areas. Whether, for example, the interpretation is that the private sector should be leading, particularly as it relates to some of our core essential health services. One might suggest, for example, that the public administration of Medicare and Medicaid is far more efficient than private sector payers in their administration of commercial insurance. But setting that aside, I think the larger issue, and I think this to some extent was touched on by Chara Abrams is, which is rather than looking at this as an either or, we ought to be looking at it as a yes and. In part because the truth the truth is that pretty much the overall investment that we make as a society in population health, broader health improvement, is quite paltry, and there is plenty of room for expansion into this arena across the board, both in the public and the private sector. Another key reflection this brought up for me is to some extent the study reflects a temporal challenge in that for the most part hospitals have little demonstrated capacity to undertake a lot of population health activities. It's clearly reflected in the fact that the vast majority of what is currently reported is in the form of charity care and public pay shortfalls. What some of my colleagues in the hospital arena would call lazy charity. That is waiting until people make it their way into our emergency rooms and then spending a lot more money to treat things that are clearly preventable. I think there's growing interest and growing innovation among hospitals in stepping into this arena, but we are still, I think, on the front end of that learning curve. The ACA presents an immense opportunity to the degree that we have cooperation at the state leadership level to allow the Medicaid expansion to occur, and then at the federal level to really look at creative ways in which our financing models shift and reinforce this stated movement from cost to value, that beginning to shift towards basically hospitals being increasingly at risk and incentivized to keep people healthy and out of their institutions, rather than the fee-for-service incentive to conduct procedures and fill beds. So in that sense, we have a plenty of room for expansion, frankly, in both the public and the private sector in the population health arena. So while I think it's a really important area of inquiry, it highlights a question that I think is a reasonable question. Our real focus now is on how we both build population health capacity in our hospitals, and on a parallel basis, the way that we do this in our local and state public health agencies. My own observation, and it's borne out through a lot of data analysis, is that many of our local public health agencies don't have the capacity to do the kind of comprehensive health planning and implementation that is needed in their communities. We have limited epidemiological capacity in most of our health departments, and much of what health departments deliver these days, in fact, are relatively siloed categorical services. Not necessarily because they want to, but this is what have been the way that priorities have been articulated and advanced in our state legislatures. So there's a good amount of learning and coming to realization that is needed as it relates to how we allocate public resources to our local, to our state and local public health agencies that really support them playing a role as a convener, as a monitor, as the facilitator, as a connector. Using Chara's reference to the whole concept of collective impact, we can't have that kind of connection if there aren't entities that can step up and really facilitate, connect the dots, and take advantage of the synergistic opportunities that are available. So that really leads us to think about, for example, not just how our public health agencies get a slice of the pie, in essence, of the dollars that are currently allocated for medical care, but how the public health agencies work with hospitals, health systems, and other members of the provider community and payers to devise ways in which they can work together with other stakeholders in the health sector, the United Ways, the community action agencies and others, as well as increasingly engaging the community development sector and looking at ways in which to channel dollars that provide funding for affordable housing, for grocery stores, for child care centers, fairly qualified health centers, and others as a part of a comprehensive health improvement strategy in our communities. So in essence, the larger question is how do we make this notion of population health improvement the job of everyone? How do we build this concept of shared ownership in our communities? And in general, recognize that there is, before we can even talk about crowding out, we need to talk about how do we dramatically increase our investments in comprehensive population health improvement. Thank you very much.
Thank you, Dr. Burnett. Dr. Mace, you have the line.
Fantastic. Thanks, E.B. I'll be brief because this has been such a wonderful wonderful session. First of all, I just want to start by saying thanks to our speaker and our commentators for being a part of this discussion today. We're really privileged to have Simone, this work by Simone and Gary Young, two of the premier researchers and scholars on hospital behavior and market structure and performance. And it's great to see people as talented as Simone and Gary and her colleagues at Michigan, folks like Jeff Alexander and Daniel Yushu Lee, who again are really, are international experts in hospital markets, hospital behavior. It's great to see them turning their research lens into looking at this interface between the public health sector and the hospital sector and helping us make sense of the interplay, the interactions, and helping us lurch forward toward finding some ways of better aligning the public health and the healthcare sector to realize improvements in population health. And the same can be said for these the commentators we just heard from. Kevin obviously is a long-standing, well-known, widely recognized scholar of both healthcare policy and public health and prevention policy, and to hear his insight, very, very helpful. And then Chara Stewart as well. Great to be on the panel again with her. Chara and I actually worked together for about 8 years in Arkansas on the issues around trying to address cancer disparities in rural and underserved populations. And now her position at one of the nation's leading hospitals and research hospitals, and the role that she's playing in leading community benefit activities for that very important hospital enterprise. Hearing her perspective on some of these issues, I think is a very valuable and really very unique opportunity for those of us who do this work from a public health standpoint. Just a few other things to kind of caught my interest I might plant for discussion. I mean, I definitely want to hear questions and comments from our audience members. But I guess first of all, just again about the importance of the topic here and understanding these issues of crowd out between public health and hospital contributions to population health activities. Simone said, well, the results here are perhaps not surprising if you know a bit about the public health system and a bit about hospital community benefits. But on the other hand, this is still an area of active scholarship, an area where we have some conflicting results and where there are real policy concerns about crowd outs and what that tells us about the value and the merits of policy strategies designed to increase public sector investments in public health and population health activities. Some of you may have seen the recent paper by some of our colleagues at Georgia State, Jim Martin and Jason Singh and Peggy Honore published a paper a month or so ago looking at public health spending in the state of Georgia, and they actually find their estimates of adverse effects of public health spending on population health in the state of Georgia, taking advantage of a specific funding mechanism state funding mechanism for public health in the state of Georgia. And their conclusion, one of the plausible explanations for that finding that increases in public health spending lead to actually worsening mortality, preventable mortality, as well as worsening morbidity, One of the plausible explanations in the discussion section is crowd outs, is that this public health financing mechanism in the state of Georgia may be crowding out private sector investments and activities, and that could explain the inverse association. I actually took on that conclusion a bit in the Health Affairs blog last month. I think there's more methodologically and from a measurement standpoint that likely lies behind that they're finding. So I've pushed them a bit to take a closer look at that. But nevertheless, this is an active hypothesis and an active policy issue about the potential for crowd out here. Again, when you think about public health activities and population health activities as being having largely the attributes of public goods in terms of benefits being non-excludable and non-rivalrous, and many times these activities having beneficial, positive externalities, we know that those kind of properties, in the private sector tends to underinvest in those kind of properties, and so that may lead us to expect not to find crowd outs. If public health activities and population health activities are currently being under-provided in the private sector, then public sector investments we would think would not have a large crowd out effect in terms of that activity, and that's certainly consistent with what Simone and Gary find. Another factor that kind of comes to mind when I hear Simone's findings here is this issue about our public health and private investments in population health. Are they complements or are they substitutes? If they're substitutes, if we're doing much the same thing in both the public and the private sector, or with public and private sector monies, and there's one substituting for another, then we would expect to see crowd out. However, if they're complementary activities, if there's some division of labor in what the public sector does in this area and what hospitals do, then we might not expect to find crowd out. We might actually find some synergistic effects from what the public health sector does and what the hospital sector does in this arena. And I think this is an area that's where we need to do some more empirical research. We've taken a look at this same issue using a different data source, using our National Longitudinal Survey of Public Health Systems, where we're able to look not only just at aggregate investments in these activities on the public health side and on the hospital side, but also look at the specific types of activities that are being contributed by hospitals and by public health agencies. We actually do find some pretty strong evidence of complementarity, not substitution, but complementarity when it comes to what the public health sector does and what the hospital sector does in these areas. And so we presented some of those results at the recent Academy Health meeting, and have some ongoing work in that area. So I think in general this is an excellent, very policy relevant topic that we need to be investigating now in the context of health reform, community benefits activities, and the public health sector reinventing itself in the context of these larger changes. It's also, this topic, very, very relevant to where we're going with the Robert Wood Johnson Foundation and its next generation of research focused on a culture of health, trying to better understand multi-sector activities that relate to population health and creating a culture of health, trying to better understand the how to better align the public health and healthcare and social services sectors and the activities and their financing mechanisms and expenditures in ways that can maximize the aggregate population health impact and maximize the impact on the foundation's goal of creating a culture of health. So you've teed this up. Actually, I look forward to further work out of this group and our larger field. Thanks so much.
Thank you, Dr. Mays. And thank you to all our commentators too as well. And so we're opening the lines now, or the chat box, to questions. And we'll start off with Patrice, who has a question to not only to Simone, but any of the three commentators are feel free to also chime in. Are they any aware of any studies looking at the relationship of hospital spending on community health and rates of infant mortality in their community? So Dr. Scotchell mentioned two examples, Henry Ford hospital systems in inner city IMR and inner city Detroit, but not much on categorical programs. So if there's anyone from the panel who'd like to give Patrice some ideas. Okay.
This is Kevin.
Go ahead,
I would Yeah, I would also take a look at the work that Collaborative of Hospitals have been investing in Milwaukee as well as a good example of that. Just to take the question a little further, I think what we're looking at is the degree to which there is active publishable research that looks at a specific issue like infant mortality, which is of such a high level and important enough that people do come together in a number of communities. The Henry Ford Health System is a key leader of this work in Detroit, but they are working collaboratively with a variety of other stakeholders. So in that context, it is important work that is going on, but increasingly what we're confronting in the research arena is the degree to which it is the driving issue is impacting rates at the aggregate level versus attribution of that impact to a specific intervention of a specific organization. Increasingly, what we're coming to grips with is that many of these problems are far more complex than can be effectively addressed with a single intervention and or by a single stakeholder. And going forward, looking at with the well-crafted terminology of our colleagues at FSG with collective impact, they've in essence captured what many have talked about for decades, which is how do we more effectively collaborate? How do we, using Glenn's framing of looking at complementarity, how do we look at ways in which to leverage the expertise, the differential expertise and experience of different stakeholders to address these complex problems and their underlying drivers? So it's clearly reducing infant mortality isn't just about engaging a mother in the first trimester. It is about a variety of other broader drivers of poor health that have to be addressed if we're going to both achieve measurable outcomes and sustain those outcomes over time.
Thank you, Dr. Barnett. I think we have one more question from Dr. Scotchfield, again to the panel, or Simone. Is there any data on places where where these partnerships exist or collaborations, and with data on census expenditures and also local health department expenditures, were they tracked? Any idea on that? Simone, of these other data sources?
I'm not personally aware right now of like a comprehensive data source that would have that information in it. But I think as I alluded to, I think the next step that I think maybe enlightening in this line of research is to really try to find either states or regions or specific communities where we have more information, and then really specifically study what's going on there, because as I mentioned, having a national data set is great from many perspectives, but there's also just a lot of limitations, and there's so much going on at the local level, as Kevin also just alluded to, that it's really hard to have a very high level perspective and really understand what's going on. But yeah, I think that may be a great next step to try to find partnerships and see whether we can get better or more detailed information from those partnerships.
So with that, we'd like to thank you so much, Dr. Simone Singh, for your presentation today, and we'd also like to thank our three commentators, and we'd like to also thank everyone for joining us for today's webinar. And don't forget that we have another one scheduled for August 12th, and the questions, and you could also access the archives, our website, for the archives of our past webinars too as well. And with